Here's another one where this demonstrates during the illness how they can't organize, they can't connect, they very grotesque, carry really broad stroke, almost like this would be like a 2 to 3-year-old drawing, maybe barely 4. And here's her recovered drawing to do the contents. OCD is also accompanied by, or EC, again, these are all the things that accompany, these are choices, motor abnormalities and sensory abnormalities. So this would include handwriting, as I mentioned, we know it as dysgraphia, where some kids already had that diagnosis. Choreiform, which I can't see me, but if you hold your hands out and start to play like you're playing the piano, that is a choreiform movement. That is specific to strep only, by the way. They're hyperactive, and sometimes they get so hyperactive they do backflips and spin and cartwheels in totally inappropriate places. I had a child who was backflipping so bad in his small pediatrician's office, and we had to take him out of the hallway because he would have kicked somebody doing it. Inability to dress, I mentioned, do regular activities. They don't shower, they don't brush their teeth. Sometimes parents have to get them dressed. And motor and vocal tics can be extremely severe. But I want to make a point here that in 1998 to 2013, remember I said the diagnosis changed in 2012, it was around 2013 actually, that the PANS diagnosis then officially changed so that tics, which had been originally, the original diagnosis would either you had an initial onset of tics or OCD. Then they changed it and put tics down here and made eating disorder the top. It wasn't that the illness changed. It was a political decision because neurologists really rigorously fought that tics are not PANS. This is still a controversial issue with them, and because they wax and wane, as do PANS symptoms. And but these tics, when they come on and they come on suddenly, are debilitating often. And unlike Tourette or a tic disorder, which it's normal for kids to have tics like 5 to 7, and then if it's Tourette, it starts to develop often more, and then the vocal part comes in or the motor part comes in. And there's a whole diagnosis criteria for Tourette, but these kids have Tourette's overnight. And therefore they're getting misdiagnosed because you have to have Tourette for 6 months these tics, before you even get a diagnosis. They also have huge changes in lights, sensitivity issues, lights, noise, smells, taste, textures, sensory seeking behaviors, even having particular things to touch. They might be clinging to a blankie or a toy. I've known of kids who pack that toy to bring them to school. And often they're complaining about lights, how you chew, how you close your mouth. They can't eat with you. They can't smell foods they used to do. They can't taste foods. Things taste very different. They tend to also start to crave carbs and sugars. There's some biology behind that, which I'm fully not capable of explaining, but it is occurring in terms of food choices. Sensories include also, on a more extreme version, you can have psychosis in this illness. About 10 to 13% has been measured. Visual hallucinations are not uncommon when you're in this state, including very frightening images, altered perceptions, which was called the Alice in Wonderland distortion. I had a child she would sit in her closet because when she'd open the door, she was either a tiny little thing like a mushroom to her furniture in the room, or the furniture was like a little tiny mushroom to her big body. She literally was like Alice in Wonderland with her vision. And then children say it's like a nightmare when I'm awake. They also can see very scary images, such as their parents getting killed, their intruder, they got injured by an intruder. Auditory hallucinations don't happen as much. It's mostly visual, which, by the way, in psychiatry even, is often a question mark, and the type of the hallucination, like spiders growing on you. I just had a kid the other day, I worked up, she saw bugs in her food all the time. And so this is a visual hallucination. That kind of hallucination is usually neurologic. When my father-in-law was having sort of a brief dementia moment, he saw hangers hanging over the wall. He saw bugs on him. He was actually iron deficient when he saw bugs. So it's usually a neurologic or physical reason that visual hallucinations become this way. Urination and somatic. Somatic is the body. So now we have urination issues, urgency, wetting the bed or pants, frequent trips to the bathroom. When they're wetting, this is a child who's been dry. It's not a child who's still in sometimes at 12, up until 13, they're going to have enuresis at night because the family history is strong, the genetics are there. These are kids who've been dry. So if you see a kid who has been dry if I see a kid who's been dry at 2, totally potty trained by 3, And now they're starting to wet their bed at 5. You have to look around and say, what would that be about? Now, did they move? Yeah, but that would only be a couple transitions. Do they have a young sibling? Yes. But it is not to be continued if it's normal. Or if you're really, really tired, some kids are really heavy sleepers and it makes them harder to wake up. But this is different than normal. They're often checked for UTI. So when I look at their histories, they've been to the doctor looking for a urinary tract infection. They have trouble falling asleep. Their sleep is awful trouble going to sleep, falling asleep, nightmares, REM sleep disorders where they're moving during their sleep and not supposed to, sleepwalking, falling out of bed. They have a lot of concerns, often with toileting, contamination fears. This is where the OCD comes in. Tremendous amounts of stomach and abdominal pain and body aches. And if you have a tick-borne issue in the background, there's a lot of bone and joint aches. So symptoms are not in the diagnosis rule out. You got to say, are symptoms better explained by a known neurologic or medical disorder? I just mentioned for the visual hallucinations, you need to ask yourself, is there a reason medically that they're having hallucinations? So this is where the DSM, which is the Diagnostic Treatment Manual, is important because it also says, but wholly pretty much forgotten by my profession, psychiatry, that the first step in treating a health condition is to see if there's a medical or mental, if there's a physical thing that's happening that causes these symptoms. So for example, if I'm treating geriatrics and a person comes into my office and they're suffering from depression, and I take a good history and find out they had a heart attack within the last year, that is almost predictable because a very large amount of people post-heart attack have depression that is stimulated by the heart attack. It's an inflammatory disorder. Now they have depression. And I mentioned before, the clinical diagnosis is done through history, rule outs, supportive lab work, and not by lab work alone, which parents often want the labs because they're sure that's going to show them everything. But unfortunately, when their pediatricians do some of the lab work sometimes, it doesn't show up, and they definitely say you don't have PANS, which in fact you might actually still have. This is the basal ganglia again, and I'm going to show you because it connects to all sorts of other issues. Here's the multi-parts of it. It also works, again, on interconnection. You'll see why in a minute. But also here is where all motor movement occurs. All blinking, smiling, swallowing. So any tic that occurs out of the blue only comes from this area. This is the area where if you have Parkinson's, your dopamine is kind of being diminished. In tics, the dopamine is misfiring, and causing movement. It's also where executive function, behavior, and emotions are somewhat monitored, although emotions, as I mentioned before, is down the limbic system, the executive function from the frontal cortex. Disorders of the basal ganglia we know include tic, Tourette, addictions, because there's an award center in here, Parkinson's, tremors, Huntington's disease, which has writhing movements, Wilson's disease, it's just a copper disorder. So what goes wrong with immunology? I'm not going deep into this, but the main ingredient here is the IgG, which is, as I call it, the immune system in your blood, like the Navy. So it floats everywhere. It's in your lymph systems, your blood, it's in your brain, is in your blood. And it goes to war. So what happens is called cell mimicry. So the basal ganglia, as I mentioned earlier, this looks like strep all along the edges of the parts of the basal ganglia. There's little markers that tells the body what it is and what should interact with it. But those little markers look suspiciously like strep to the antibodies. So the antibodies get into the brain because this is called leaky brain, which is where an inflammation or an illness like COVID actually has caused leaky brain. And it seeps in, and then it says, oh, there's the strep right here. So it starts attacking it. So I say to the kids and families, it's got the wrong intelligence. It's bombarding the wrong place. But as a result, the shelling causes this area to enlarge. Brain scans have shown in basal ganglia, PANS, OCD, and Tourette's, by the way, this area is enlarged. So that makes you wonder, well, is OCD and Tourette's inflamed? It's an inflammation disorder. Maybe it's not strep, but maybe it is, or maybe there's some other reason it's inflamed. So this is why the basal ganglia is so important. So now right in the middle there, where right above the AMY, which is the amygdala, and the hippocampus is where all your short-term memory is stored. And the frontal cortex is your executive function and your focus and attention. Notice all these little black lines coming from the cerebellum on the right side. These are the dopamine tracks. So they created in cerebellum, they all go through the basal ganglia, and then they go to all these different areas. So when you see the diagnosis, you're seeing all these different areas being impacted. What's not on here is visual, sensory, but here's your thinking, here's your motor tic, here's your emotions, here's your amygdala over here again in the hippocampus. So it's kind of like this grand central of your dopamine tracks, and how that inflammation impacts those tracks then presents the symptoms. These symptoms can be really extreme. You can have barking, ticking, barking, licking shoes. Those are actually, I should say, that's wrong. It's not compulsions. Licking shoes might be a compulsion, but barking is a tic. I had a girl in my office recently doing it. Motor and phonic tics, whooping, wringing hands. Sometimes this is the presentation. This is the only symptom sometimes, as I mentioned, tics. You can have terrifying episodes of anxiety, depression. The brain is telling them terrible things might happen, as I mentioned. And then there's this overlap between the symptoms and other illnesses that a person such as myself is trying to figure out, is there really any illnesses that I'm missing or truly been diagnosed? I mentioned you can have ADHD already. You can have dyslexia already. But also if I'm meeting a girl in middle school, 7th or 8th grade, and she's having trouble focusing, I'm now wondering, is there an attentive part of ADHD that's showing, because this is when often you see inattentive type ADHD presenting itself when they enter more complex information learning in school. And I mentioned hallucinations. I won't go back on that. So what do we do to treat it? So first, diagnose it. So ideally you have a throat swab that your primary care will do, and you ask for it to be both rapid and you send it out for culture. In younger children or even in teens, a bottom review should be done, because if it's reddened area, which often looks like yeast, especially for kids, you have to differentiate between yeast and the reddened area right around the anus area. They often have strep in their anal area, and that needs to be swabbed with a little swab. Nasal swabs are done possibly if you have a physician. I would like to do in the future, but I don't have a medical person on hand to do. Sometimes in the nasal swabs, you'll find staph and other infections. I had a girl who was operated on recently, and they found a pus pocket in her throat, and they had staph, candida, and I can't remember the third one, but 3 infections were in that throat, in a pus pocket that she was reacting to partly. Blood work, though, is one of the things I do rely on, and that is because if you have strep, even if they don't know you have strep, I should have said, throat swabs do not always collect the strep that's there, because the throat swab has to be done very rigorously, to the point, as Sue Sweda would say, they're going to throw up on your shoes if you're almost there. You're just right before they're going to throw up. When she surveyed many kids at NIH as to what was the worst thing she did to them, including cerebral spinal fluid taps, they said the throat swab was the worst they had to do. But also, people don't always have it in their throat. They might have it in their nose, as I mentioned. They might have it in their stomach. They might have it in their anal area. So it's not always in the throat. And the reality from Dr. Pasternak, who's infectious disease at Mass General, will tell you that, maybe 30, 40, 50% of your lucky throat swabs are positive for strep, in fact, but they still have strep. So what happens is when strep is in your body creates antibodies, and those antibodies can be measured. You don't measure it right away if they have a strep throat, actually, because the antibodies elevate over 4 and 6 weeks. The antistreptolysin 4 weeks, the DNase peaks at 8. So often you see an infection or a sore throat that went away. You didn't even swab it. You didn't go to the doctor. You get out a sore throat for one day. It's done and over. And 6 weeks later or 8 weeks later, they start to have these symptoms. That is connected. There is a connection to the sore throat, or somebody in the family having strep, but not the child with PANS. And now 6 to 8 weeks later, you have a kid who's having a lot of psychiatric problems.